So we're here today with Tom, who's a 70-year-old male. When we arrived, Tom was sitting in his lazy boy and complaining of chest pain and palpitations. We've spoken to Tom and we know that he's had a previous MI about 5 years ago, but he stated that the chest pain he's feeling today feels different and that he was unable to stand due to a syncope and dizziness. We know that Tom is on Clozapine and taking aspirin. We've since had Tom lie supine. He's pale, he's clammy, and he's now unable to obey commands. We've taken a set of OBS, and our OBS were a heart rate of 170, and looking at the monitor we can see that he's in VT. His blood pressure was 70/40, rest rate of 18, blood sugar of 7.6, and rest rate of 37. We've then printed out a 12 lead, and we can see on 12 lead that he's not an SVT with apparency. Due to Tom's condition, we are calling for backup. AT1 calls comms.
Go ahead, AT1.
Requesting R50, patient is status 1.
Copy, they're on their way.
Going through Tom's history, we were able to rule out electrolyte imbalance. Given his temperature and other presentations, we rule out sepsis. So we'd look to cardiovert. Going through cardioversion, we have our resus kit ready to go just in case. And before Tom became unable to obey commands, we'd had bilateral IV lines put in. So going through our cardioversion checklist, we've placed our pads on the apex and sternum. We also could have put them posterior and anterior. We'll ensure that our defibrillator is in manual mode, which it is. And we select the lead with the biggest R wave. We then also check that there's no artifact, which there doesn't appear to be, and select synchronized mode. We'll then confirm that there is a detection symbol over every QRS. Which there is. We'll next ensure the patient has received adequate sedation if required or indicated. Tom wasn't able to obey commands, and we'll just check that he's still not obeying commands. Tom, can you hear me? Hello Tom, can you answer me? And Tom's still not obeying commands, so there's no indication for sedation. If there was, then we would look to sedate with ketamine. So next we will select the joules. On this monitor it's 360, which is the max joules. We'll charge the defibrillator, making sure that everyone is clear. To deliver the shock, I'll hold down the button until the energy is delivered, and then we'll reassess Tom's rhythm. Everyone clear, shocking now. So the energy has been delivered, and we'll reassess Tom's rhythm and cardiovascular compromise. Just turn off that alarm. So the monitor is showing that Tom's now in normal sinus rhythm with a rate of 72. So we'll just check for a pulse, and we're getting a pulse that matches the monitor. So we'll now go through and give Tom another set of OBS and look to transport to hospital, possibly meeting our R50 on the way. If it had been needed for a second cardioversion, then we'll confirm that the defibrillator is still in synchronized mode before looking to convert again. We've responded to a 40-year-old male today who's fallen off the roof onto a concrete driveway about 6 metres down. His neighbour has called 111, and she stated that he was water blasting the roof, and she believes he slipped and fallen onto the concrete driveway. She's been unable to assist because she's not fully mobile. A secondary survey and a trauma sweep has revealed that he has an isolated injury to his occiput, with an obvious boggy patch of about 6 centimetres in diameter. The patient is currently lying supine and assessing his GCS. He has a current eye score, his eyes are opening to pain, which is a score of 2. Verbally, he's moaning, which is a score of 2 as well. And for a motor score, he's posturing and extending, which is also a score of 2, giving him a total GCS of 6. Given that we're currently treating him down the TBI pathway and his GCS is under 10, which is an RSI indicator, this patient's currently an RSI candidate, So we're going to call for an R50 for an ISI. A21 calls comms.
Go ahead, A21.
Requesting R50 for RSI of a status 1 TBI patient.
Copy, they're on their way. 10 minutes. Can you start the RSI preparation procedure, please?
Copy, understood. So we're now going to prep this patient for RSI. We're going down the TBI pathway as well, so we consider fluids. However, his current BP is 160/90. So that's not currently necessary, but we do have a fluid bag prepared and ready to go. We'll go through our RSI checklist. The first step is to attach nasal prongs. So we have these attached on the patient, but they're not connected to the oxygen or running at the moment. The next step is to pre-oxygenate, which we'll do with a reservoir mask. So let's place this on the patient's face and then have it running at a flow rate of 10. Ready to go on 10. The next step is to attach the monitoring equipment, which we already have in place, an ECG, BP and SpO2 monitor, and we also have our capnography ready to go as well. Next is to place the monitor where it can be seen, which we have done, and we've also got lots of space to our right ready for the intubation equipment. Next is to gain IV access, which we've already done bilaterally with 2 large bore IVs. And as said before, we've got a running line prepared of sodium chloride, which is not currently running, but it is ready to go. The next step is to position the patient for optimal airway control. We have the patient lying supine and a towel placed under his head in the sniffing position. Next, we'll have our ETT tube holder, which I'm just going to place under the patient's neck so that's ready for use. Going through the checklist, I'm now going to check that our suction is working. Which it is. And I'm going to place this next to the patient's head as well, ready for use if it's needed. We're also just going to have our manual bag mask valve ready to go as well. Check that this is working. The PEEP is also attached and ready to go with a mask in case it's needed. The next step on the checklist is to obtain said vitals and if possible update the responding ICP with the patient's condition and vital signs. So we'll do this now. A21 calls comms.
Go ahead, A21.
Just wanting to update our responding R50 with the patient's condition and vital signs.
Go ahead.
Patient is currently still status 1 with a GCS score of 2 to 2 for a total GCS of 6. Patient's vitals, BP of 160/90, heart rate of 50, rest rate is 12 and irregular. All other vitals are within normal range.
Copy.
And the last step on the checklist is to prepare the area. So we've currently got our patient set up. There's space on either side of the patient for easy access for anyone who needs to treat the patient. We've chosen not to extricate as our R50 is quite close and the space that we have here is adequate for an RSI. Would also just like to check my failed intubation drill just in case it's needed. So should the ICP be unable to get a successful intubation, we'd remove the ETT and go back to basic airway maintenance. And so we have sized and prepared an MPA, OPA and LMA in case they are needed. And should that fail, we've also bared the patient's chest so that we have easy access ready in case a crack is needed to be performed. So that's the end of our RSI checklist. While we're waiting for the R50 to arrive, we'd also just look at any other patient treatment. The patient's becoming combative and slightly aggressive, so consider giving morphine. However, given that our R50 is quite close and the medications that are going to be delivered to the patient for RSI, I would hold back and wait to, I wouldn't deliver morphine to the patient, I'd wait for our R50 to arrive and make that decision. However, we do have the IV lines in place should we decide we need morphine in the meantime.